I would like to call upon the next chairperson, Dr. Pooja UK, who's the consultant endocrinologist at Tata MD Clinics and Manipal Hospital, Malleshwaram, Bengaluru. We welcome you on stage, ma'am.
Good afternoon, everyone. So coming to the next session on inhaled insulin. So we have Dr. Basavaraj, consultant endocrinologist at Narna Health. He doesn't need any introduction. Sir is our mentor and for all of us. So let's see where we can use this inhaled insulin and what are the indications. How can you adjust the insulin and how to change from injectable insulin to inhaled insulin. Over to you, sir.
Thank you. Thank you, Pooja. And that's indeed an honor to be called as a mentor by someone, colleague like you. It makes me feel older also. But yes, for sure, thank you that I have added some value to your professional career. So the talk is a sponsored talk, trying to understand about the inhaled insulin, clearing the air around inhaled insulin. Okay, so this is our agenda. Insulin, we understand it's been a century old, so just briefly touch upon that. Inhaled insulin for diabetes mellitus. What's the evidence with the current product, and to conclude, what do we have here? So insulin, we understand this has been around for a century for us to be used. Initially, it was an animal-based insulin, human, and then being produced by an rDNA technology. Then this has been improvised by the pharmacokinetics also, basically by acting as an intermediate acting insulin, then came the long acting, then came the ultra long acting insulin, short acting insulin, then we have got rapid acting insulin, then we have got the ultra fast rapid acting insulin. So we have got syringes also from reusable injection syringe. I think quite a couple of our seniors also told that insulin typically used to be given by probably those needles which had to be boiled and then given subcute also. But then again, I haven't seen anything, but have received those deep IM shots during my childhood by GP general practitioner though. But then again, these are all, from there we have moved on to disposable injectable syringes, dial-up injectable pens, and the intelligent pen. So a century-old wonder, invasive route of administration of insulin is the only problem with insulin is what one of the major problems with the insulin usage. How many of you feel patients, it's a difficult task for the patient to convince for an injection? Can we have a show of hands? Probably yes. So, and that leads to decreased discussion of insulin with our patients. Yes, no, again show of hands? Yes. So then that is what is known as the psychological insulin resistance. So it's there in our mind, it's there in the mind of the patients that probably this is the terminal or failure of the diabetes story and being pushed to insulin. That definitely does not help with the inhaled insulin, but definitely what comes to rescue for inhaled insulin is that the initial inertia or the acceptance of insulin probably is a little bit more friendly there, is what we understand. So inhaled insulin is the only non-invasive insulin currently approved for use in diabetes mellitus. So 2014, US FDA gave approval for Afrezza, again developed by Mankind Corporation, and then Cipla collaborates with Mankind to license Afrezza in India. In 2024, it has launched Afrezza in India. So the only inhaled insulin available for use, it is rapid-acting inhaled insulin indicated to improve glycemic control in adult patients with diabetes, formulated using a technosphere technology, what we call TSI, technosphere insulin. Insulin is adsorbed onto the carrier particles, which is called as FDKP, fumarate diketopiperazine and polysorbate 80. And then it was approved by US FDA 2014 for adults and even including pediatric population of more than 6 years. But in India, it is only approved for the adult population. So please remember that. And then compact inhaler, pre-filled single-use cartridges of 412 unit cartridges and breath-powered delivery is that. So basically FDKP plus water plus regular insulin gives us this magic of pH of less than 6 called as technosphere insulin. And at a pH of more than 6 in the respiratory pathways, it gets absorbed very rapidly and then crosses the lung membrane and causes its effect. So this is the ADA 2026 recommendations. So it suggests that inhaled insulin has got pharmacokinetic faster than those of the rapid-acting analogs, and then has got demonstrated faster onset and shorter duration as compared to your RRA insulin Lispro, and has got some precautionary note as in a resulting in a decline in the lung function. So these things we'll discuss here. What's the evidence? Plenty. So more than 60 clinical studies, more than 6,500 patients studied, and then 3,017 of type 1 or type 2 who have got pooled safety data. And then phase 3 trial data is also there. So that is called as type 1 data is affinity 1, inhale 3 study. And then type 2 diabetes is affinity 2. And Indian phase 3 study is also there. So there has been a good Indian phase 3 data coming out on 216 type 2 diabetes patients, randomized double-blind placebo-controlled arm of 24 weeks there. Okay, so the pharmacologic profile, it's a faster-acting insulin. Afreeza's peak time of action is 12 minutes, whereas your Lispros comes actually around 17 to 30 minutes, almost as similar to endogenous insulin here. So similar A1C reduction with significantly lesser hypoglycemia compared to your rapid-acting analogs, basically because it acts quicker and fast, clears quickly. So probably the late post-prandial hypoglycemias are lesser. But having said that, heavy meals, predominantly your fat-heavy meals, need to be dealt here very carefully when you are using a inhaled insulin. Similar A1C reduction compared to that of insulin aspart, and significantly lower risk of hypoglycemias, again because of the faster onset of action. So technosphere insulin is non-inferior to either of the protocols you use for maintaining the glycemic control, and the TBR, that's your time below range, your hypoglycemias are also comparable to that of the Lispro insulin. So there was a significant A1C reduction, clinically meaningful reduction in PPG, and hypoglycemic events were higher with TSI compared to that of the placebo on oral drugs there. So significant A1C reduction when added in type 2 diabetes patient uncontrolled on oral drugs, significant HbA1c reduction at 12 weeks, hypoglycemia reported as one of the most common treatment-related side effects, and no difference in FEV1 at a week of 28, which was seen in this patient population. Technosphere insulin and special population. So diabetes mellitus along with renal impairment, very cautious, I would not use predominantly unless there is a good discussion about the pros and cons, not approved as though. Hepatic impairment, similar is the case. Breastfeeding, lactation, we do not have a lot of data there. Probably one of the most ardent group of people is people who are of the elderly age group. So there who have got needle phobia or probably needle lethargy, they are one of the good candidates. Most of my patients who are using these inhaled insulins, couple of them who are on basal bolus, who are into offices and who cannot inject in front of everyone, that's one. And typically elderly people who are staying probably alone and who have got a little bit of needle lethargy and too much overwhelmed by the needle pricks, probably decreasing the needle pricks there helps. So clinical safety, most common adverse event is cough. Cough was seen in 25% of them as compared to that of placebo. Throat pain, irritation, headache, diarrhea, and others were non-significantly there. Cough with TSI, so reported in 26.9% of Afreeza patients versus 5% of the comparator. Cough was generally mild, and then dry occurred within 10 minutes of inhalation, was transient and declined with the continued use. Cough was the most common reason for discontinuation from clinical trials, and 2.8% of patients treated with Afreeza discontinued therapy because of cough in clinical trials. So lung safety data with Afreeza has been evaluated in 2-year data. Changes in FEV1 has been noted in much of these trials, but then again that's not very significantly severe enough to cause stoppage of the Afreeza. So the changes in FEV1 were small, occurred early, remained non-progressive up to 2 years, and resolved when treatment was discontinued. Probably typically if the change in FEV1 decline is more than 20%, that is again a point where we stop using Afreeza. If the cough is persistent and then we do not find a cause, that's also a point where we stop using Afreeza. So change in FEV1. So then what we understand is that around 5% is the change usually what is seen in patients in this phase 3 clinical trial. Lung malignancy, so not much of long-term data is available for lung malignancy. 2 cases of lung cancer, one in control, one in uncontrolled trials. 2 cases over 2750 patients of exposure. Both cases had prior history of heavy tobacco use of roughly 40 pack years there. 2 additional cases of lung cancer have been reported after trial completion. So then again, the data is insufficient to link the causality there. So again, back to basics. So typically, who are good patients? Who are those who do not? What you have to do to take Afreeza there priorly? Number 1, check FEV1 history, no respiratory illnesses, typically COPD and asthma. Second, check FEV1, and probably it has to be more than 70%. Third, they should not be having predominantly any lung disorders or some of those kinds. I'm missing something. So yeah, we'll keep discussing and then we can see. And someone who's got uncontrolled or non-explained cough for a long time, so there also you'll have to first evaluate and then take a call. And do an FEV1. These are the patients who who can take Afreeza. Adults, basically any adults who are on basal bolus insulin. Who cannot take Afreeza is typically patients who are current smokers who have quit smoking recently. That is, you are less than 6 months of quitting smoking. What does a current smoker stand for? Any smoking. Even once in 2 weeks, 1 or 2 sticks, whenever I smoke, he is a current smoker, and probably Afreeza is not so much encouraged in them. And recently quit also, less than 6 months, probably do not encourage, or rather I would be skeptical on starting any of these drugs. Asthma, COPD I have spoken, hypersensitivity to insulin, do not give those. If you are not able to follow with FEV1, then also be a little bit apprehensive and probably discuss all of these things with the patient. So they are typically the do's and don'ts with Afreeza. So this is an oral inhalation, single inhalation per cartridge, administered at the beginning of the meal. And one of the major issues what we understand is that this is not a unit to unit titration. Like you cannot go from 4 to 6, 6 to 8. No, there has to be 4, 8, 12. So you'll have to use the most appropriate dose which has been there. Up to 4 units, then probably use the blue colored cartridge. Then 5 to 8 units, 1 green color cartridge. 12 units, you can either combine a 4 plus 8 or a 12 unit. And then basically based on those things, you'll have to change the doses of the cartridge. So this is a very simple cartridge. I think, how many of you have seen the device here? Afreeza, yes. I think a couple of them. I think you can go ahead and try to see the device. It's a small device. You can just put it in your pocket and keep moving around. So then load it with the cartridge and then load, inhale and then remove and discard it. So Technosphere insulin is a rapid acting analog indicated to improve glycemic control. So in patients with type 1 diabetes, must use with a long acting insulin. It is not a replacement or you cannot use it in place of a basal insulin. Definitely it's a bolus sort of an insulin with a meal insulin. So in type 1 diabetes, must use with a long acting insulin. Not recommended for the treatment of decay, no, not at all. Someone who is having severe hypoglycemia, not at all. Patients who smoke, not used. Contraindication, chronic lung disease such as asthma or COPD because of risk of acute bronchospasm during episodes of hypoglycemia, and hypersensitivity are the ones where you got to be very careful. Before initiating a TSI, Afreeza, it is necessary to perform a detailed medical history examination and assess FEV1 to identify potential lung disease in all patients. FEV1 should be more than 70% of the predicted value. Assess FEV1 at baseline, follow up closely at every 6 months, and then annually thereafter. In patients taking TSI, if FEV1 declines by more than 20% from baseline, consider discontinuing TSI. Afreeza, to conclude, is the only inhaled approved insulin for use in diabetes mellitus. Ultra rapid acting mealtime insulin along with a compact inhaler device. Oral inhalation of regular human insulin for prandial glycemic management, and found safe and effective in clinical trials. Vast database, clinical database, offers proven mealtime glucose control, prompt reduction in high blood glucose within 12 minutes, And the most common adverse reactions include hypoglycemia, cough, throat pain, or irritation. And then approved by Indian regulators, CDSCO, for adult. Remember, adult. Pediatric, we do not have approval in India for adult individuals with diabetes. So with this, I'll end my talk, and then would like to invite all of you for our very unique event, the End Obesity School. Last year also we did, and this year we'll be having at Ritz-Carlton, December 6, 2026. All are invited to please participate. Thank you.
Thank you, sir, for that wonderful talk. I think you have cleared the air around the inhaled insulin, about the advantages and where we can use it. But I just wanted to ask one question. So inhaled insulin is like a growth factor. So any long-term, the safety data is only up to 2 years. So how would you place this on a longer run? Do you want to, like the insulin, should it come to the mainstream, or should it be like only in the afternoon you give one shot where the patient can't take the so how do you place this?
Yeah, nice question, Pooja. See, there's no correct answer for this, but probably we have seen that probably there's some data for the lung cancer with this thing, but these are all not critically established sort of causative role of aphasia in lung cancer. And typically the patients who are currently actively smoking and recent cessation we would have ruled out. So patients who have smoked, COPD, who are having COPD also, we would have not given aphasia. So a vast majority of the high-risk patients would be out of this. But we have data for 2 years, decently okay data, but then longer data is awaited. So someone who is at high risk, I think someone who comes out with this question, probably you'll have to discuss the pros and cons and then take a call. But then again, the elderly patients who are probably 70, 75 or something, probably in them, I think they would be more than happy to take this inhaled shots, or someone who is very young, or rather who is not okay to take their shots in the afternoon or in the evening when they are partying somewhere out. So there, what is this? The bolus insulin can be replaced with this.
Okay, thank you, sir. So we are running short of time. I think, thank you for that wonderful talk, and thank you all.
Thank you everyone for patient listening. Thank you.
Thank you so much, doctors. I would request the chairperson and the speaker to move towards the selfie area for the group photo and the memento.